Modified Widman Flap technique. Modified Widman Flap is a periodontal flap surgery to treat periodontal pockets. It is a precise and conservative surgical procedure which is designed to gain access to the root debridement and promote healing by closed tissue adaptation or healing by primary intention. Modified Widman Flap is a pocket reduction technique which allows for precise access and biological healing. This is an ideal video for dental students, interns and clinicians who want to understand flap surgery in a simplified and a practical way. Ever wonder why some periodontal pockets just won't resolve even after perfect scaling and root planing? That is because non-surgical periodontal therapy or scaling and root planing may not be enough to eliminate deep periodontal pockets. This is where precision surgery comes to the rescue. Modified Widman Flap is one such technique that allows for precision, access and healing by primary intention. So Modified Widman Flap was introduced by Ramford and Nissel in 1974. It is a conservative periodontal flap surgery which is aimed primarily at gaining access for root debridement and healing by close adaptation. The process is aimed at pocket reduction. The objectives of Modified Widman Flap is to expose the root surface for thorough scaling and root planing, to remove pocket lining and granulation tissue precisely, and to reposition the flap close to the bone and tooth surface to allow healing by primary intention. Indications of Modified Widman Flap are it can be performed in persistent pockets of 4 to 6 mm after the phase 1 therapy, horizontal bone loss where osseous recontouring is not indicated, and areas which require precise root cleaning without major alteration of the gingival form. It is contraindicated in conditions like vertical defects that need regenerative or resective osseous surgery and pockets with inadequate width of attached gingiva. The armamentarium required for Modified Widman Flap surgery is a number 15C or 15 BP handle and blade, the periosteal elevator, Orban's knife, periodontal curettes and scalers, tissue forceps, needle holder and sutures. It is important to maintain asepsis and precise blade control during the surgery. Step-by-step surgical procedure for Modified Widman Flap. The first step involves the internal bevel incision. It is given 0.5 to 1 mm from the gingival margin directed towards the crest of the alveolar bone. A 15 or a 15C blade is used to give the internal bevel incision. It is given parallel to the long axis of the tooth and it is a scalloped internal bevel incision. The goal here is to not reduce the pocket by cutting away the tissue, but to remove the pocket lining and conserve the outer gingiva. Papillae are dissected and thinned. This is an illustration of Modified Widman Flap internal bevel incision. In the first image, you can see that a scalloped internal bevel incision is placed that allows for excision of the pocket lining. The second image represents the lower arch where the scalloped incision is given. The occlusal view suggests that there is splitting of the buccal and the lingual papillae. Second step involves flap reflection. A full thickness mucoperiosteal flap is elevated 2 to 3 mm away from the alveolar crest. Reflection is done minimally and just enough to visualize the alveolar crest and the root surfaces using a periosteal elevator. Modified Widman Flap aims for limited access, minimizing trauma and maintaining the blood supply to the tissue. Third step is the second incision or the clavicular or circular incision. In this, the blade enters the sulcus parallel to the long axis of the tooth. It is directed from the bottom of the pocket up to the alveolar crest. Using a 15 or 15C blade, even a 12 number blade can be used. This separates the remaining pocket lining from the tooth surface, allowing it to be easily removed later. This incision also detaches the attachment apparatus from the root. The step 4 involves third incision or the interdental incision. It is a horizontal incision made along the alveolar crest to detach the gingival collar from the bone and the tooth. A Ormus knife can be used, or even the scalpel can be placed between the teeth. At this point, the collar of the inflamed pocket tissue is completely excised. Fifth step involves root debridement. Meticulous scaling and root planing using subgingival scalers and curettes are performed. Removal of all calculus and contaminated cementum, including the granulation tissue from the bone and the root, is performed. This is the heart of the surgery. The cleaner the roots, the healing is better. Sixth step involves flap adaptation and suturing. The flap is placed back exactly in its original position. There is no apical or coronal displacement. This is followed by interrupted or sling sutures to ensure passive, close adaptation of the tooth surface. The closer the contact, the better the healing. Post-operative care involves analgesic and mild antiseptic mouth rinses like chlorhexidine. Patient is suggested to avoid brushing in the operated site for 7 to 10 days. Suture removal is done after 7 days. Gentle plaque control is initiated thereafter. Healing occurs by long junctional epithelium formation, providing a stable attachment and reduction in the pocket depth. Healing outcome. Healing after modified Widman flap is predictable and conservative. It occurs by long junctional epithelium formation, providing a stable attachment and reduced pocket depth. There is a reduction in the pocket depth, improved clinical attachment levels, and minimal recession compared to other flap techniques. The assessment of these factors are done 6 to 8 weeks after the surgery. Modified Widman flap is not about aesthetics or osseous correction, but to provide clean and stable reattachment. Clinical tips for this procedure involves: it is important to maintain sharp blades for clean incisions. It is better to avoid over-reflection to preserve vascularity. Use of microsurgical sutures is suggested for better adaptation. It is always important to finish with gentle but thorough root planing. It is what makes or breaks the results. So to summarize, modified Widman flap is a conservative periodontal flap surgery which is aimed primarily at gaining access for root debridement and healing by close adaptation. This allows for pocket reduction. It is indicated in persistent pocket of 4 to 6 mm where there is horizontal bone loss. Steps involves internal bevel incision, flap reflection, sulcular incision, interdental incision, flap adaptation, and suturing. Assessment of healing is done 6 to 8 weeks after modified Widman flap surgery. You can find the link to MCQs for this topic in the description of the video. We hope you liked the video, and if you did, please subscribe to the channel and hit the notification bell for update on new videos. Thank you.